Hello everybody and welcome to Pint of Science. We're coming live to you from the city of Lincoln. My name's Kay Ritchie and I'm a senior lecturer in psychology at the University of Lincoln, and I'm also the Lincoln City Coordinator for Pint of Science, so I'll be acting as our host for today's show. There's going to be lots of opportunities for you to interact with us and to ask our speakers some questions, and you can do that by typing into the comments either below the YouTube video or beside the YouTube video, however it's appearing on your screen. And what we can do is pop your comments up onto the screen so that we can ask your questions to our speakers today. So the first question I'd like to ask you is, where are you joining us from? So if you'd like to type that into the chat, we can have a look and see where you're joining us from. This is the final show of ours coming from Lincoln, and we've had two previous shows, and you can watch them back on the Pint of Science YouTube channel once they're all uploaded there. I'd also just like to take this opportunity while you're telling us where you're from to thank my colleague and great friend, Dr. Tessa Flack, who's operating everything in the background and producing our show, as she has done for our previous two shows. So let's have a look and see where people are joining us from. We've got Lynn from Barnsley. Welcome, Lynn. Thanks for joining us. And Hazel from York. Hi from York. Hi to you, Hazel. And Trish from Washington, all the way from Washington. That's quite near to my house, actually. So hello, I could almost wave at you out the window. And Sumphin from Lincoln. Hi, thanks for joining us. So there's lots of opportunities for you to ask questions, as you have done just there by typing into the chat. You can also keep in touch with us on social media. So we're at Pint of Science, and you can use the hashtag #Pint21. So the way our show is going to run today is we're going to have our first speaker, and then you'll have opportunities to ask her some questions. Then we're going to have a chat about our creative reactions that we've been running this year. So that is artwork inspired by the science that we're presenting here. And then we'll have our second speaker and an opportunity to ask her some questions as well. And I promise we'll finish with enough time for you to refill your drink before the next show if you've booked on to see another Pint of Science show this evening. So nobody's come here to listen to me, so let's introduce our first speaker, and that's Professor Mo Ray. It's my great pleasure to welcome Mo. Hi, how are you?
Good, how are you?
Good, not bad. Stable internet all round, which is handy. So I'm really looking forward to hearing about this research project that you've been running, Mo. So I'll let you take it away.
Thanks very much, Kay. Cheers. So good evening, everyone. It's great to have the opportunity of presenting at Pint of Science, and thanks ever so much for coming along this evening. The quotation in the title of my talk was taken from an interview with a family carer who was reflecting on how much it cost her as a self-funder to get a decent night's sleep and respite for caring for her father. So that interview came from a research project which was funded by the Wellcome Trust, which set out to examine the experience of older people who were paying for their own care. The project took place here in Lincolnshire and also in Brighton and Hove and Solihull with colleagues from the universities of Brighton and Birmingham. Just one other really important aspect of the project is that it was supported by older citizens who formed co-research teams in each location. And usually I don't have any of our members presenting with me tonight, but I believe that some of the co-researchers from Lincoln are in the audience. So what do I mean by self-funders? So they're people who pay for care, such as help with washing, dressing, bathing, eating, social connections, medication, or they pay a financial top-up beyond what the local authority are paying for their care. For example, families may pay a top-up for a residential care place in order to pay for a slightly larger room, or a room with a view, or to move to a care home in their preferred location. But I reckon that if I stood outside a busy train station, such as the one here, with a clipboard and asked people who pays for social care, or even what is social care, I think a good percentage of people wouldn't know the answer. And this was actually borne out in a recent survey carried out by the Local Government Association, who found high numbers of people who'd not thought about how care might be paid for. 48% were uncertain what social care actually meant, and 44% thought it was provided by the NHS, which implies that they may also well have thought that it was free at the point of access. It isn't. We hear a lot about social care in the media, especially lately with regard to the pandemic, but how is social care organised? What's it made up of? And how does it differ from healthcare? Well, it's a big field, so I'm going to give you the quick version. In its narrowest sense, social care refers to services such as domiciliary care, home care, daycare, care homes, and these businesses are almost always in the ownership of the private or the charitable and voluntary sector. And then the next layer, I guess, would be a host of other local groups and organisations such as faith-based groups, lunch clubs, social groups, user groups, neighbourhood groups, who make vital contributions to social care by offering a host of additional support and help. And then underpinning all of this provision are families, friends and neighbours who provide care to disabled people. And it's fairly common knowledge that there are approximately 7 million unpaid carers in the UK today, and this figure has grown significantly in the context of the pandemic. Now, here's the thing, social care is not free and it is not available to everyone. So how would the council work out who can have care paid for and who is eligible for social care support purchased by the council? So eligibility for publicly funded care is determined by two criteria. The first is financial and the second is based on care needs, which both have to be achieved in order to be eligible for state-funded care. In very broad terms, people with capital resources over 23,500 are counted as self-funders, so they pay for their own care. And the second test is the national eligibility criteria for care and support, which is based on an assessment of need. And to meet this criterion, you have to have significant care needs. But people who don't meet this eligibility criteria can still have significant care needs. And you might be able to see from this diagram that in 3 out of the 4 quadrants, the person would in fact be self-funding. So does this matter? Why is this important? Well, I can tell you that older people are the largest group of people who pay for their care. They've always been a relatively invisible group because they've often been under the wire in terms of involvement from the local authority. If you're a son, daughter, in-law, niece, nephew, mother, father, close friend, you may be directly involved in supporting a disabled relative, such as an older person, to find, to purchase and to manage their care. So it affects a lot of people. And of course, it can also have financial consequences for the older person and wider financial consequences for his or her family if they have one. And I think it's fair to say that self-funders are at the heart of current funding arrangements, which I'm sure you know are under considerable financial pressure after austerity measures and underinvestment in social care and growing demand. So self-funders provide a vital source of income and business to care agencies who build their businesses on people who pay, and also care homes who will often rely on self-funders either partially or fully to support their businesses too. So it all sounds pretty bleak, doesn't it? But I just want to say in relation to older people that I think this is a good news story. If you listen to many commentaries about old age, you could be forgiven for thinking that our ageing population is a bad news story. The fact that almost all of us will reach old age, surely that's a good news story. While many of us won't need care for much or all of our old age, a good percentage of us will, at least for part of our old age, and within current care arrangements, many of those people will pay for all or at least part of their care. So I just want to now unpack some of the assumptions that are often made about self-funders who are purchasing within, if you like, a care market, so that they're sort of a consumer model of purchasing care within this care marketplace. So the first assumption is that self-funders have choice. They can choose what they buy, they can choose where they buy it from, how much to buy, how much to pay, and so on. But if you think about it, to have a meaningful choice, you need to have enough knowledge about options to make an informed decision. Our research found that older people and unpaid carers often didn't know where to start to look for information and advice about care. And this created a lot of frustration and challenge as they sort of searched, often fruitlessly, for care. Unfortunately, because of issues like social care staffing difficulties, the availability of care in rural areas, it's often not easy to find care which is both available and matches what you need. So unlike baked beans and cars and sofas or just about anything you might buy in the high street, there may not be a range of options to choose from. Here's an example from our research. I contacted 28 care agencies throughout Lincolnshire and Nottinghamshire. It took me 3.5 months to find her morning carer through Marigolds. There were some care agencies that said they were expanding their area, they were taking on board extra carers. So if we would like to call them back in a month or 2 months or 3 months, then perhaps they might be able to help. And of course, buying something, especially a big purchase or something that's really important, for example, someone who's going to bath you, usually involves taking some time, or ideally some time, to weigh up the options. This is next to impossible when you're searching in a crisis for care, and also when there's little choice available. You may end up just taking what you can get. So the combined impact of managing the complexities, such as where to go to look for care, what a reasonable cost is, finding agencies who match what you need, combined to make what participants consistently reported as complex, stressful, difficult, nightmarish, tough, hard work, and so on. Okay, so the next thing that I want to look at is the idea that as a consumer, you have control over your purchase. And while we found lots of positive examples of older people feeling they had control about the care that they were buying, around things like continuity of care, good relationships between the older person and carers, there were many situations where older participants lacked control over the service that they were actually paying a lot of money for. So, for example, it was often impossible to control the realities of carers not coming at agreed times, or having different carers at short notice who older people didn't know. And when you're thinking about care, complaining can be really difficult too. So imagine, for example, that you really like the carers that are coming, but say the agency that they're coming from are providing a poor service. It can be difficult to separate out the relationship with carers from the organisational structure of the agency. And of course, the ultimate right of a consumer is to exit a service. That's tricky if you rely on care, and without it, your ability to manage is in jeopardy. Another assumption is the idea that if you pay a bit extra for something, you're going to get something better. And that's not necessarily the case with care. For a start, the cost of care is very variable. So in our research, we'd find Agency A appearing to offer precisely the same service as Agency B in every respect, but the price difference per hour could be as much as £15. The cost of care is determined by many factors outside of the control of the purchaser, including, for example, the price that the local market will bear, demographic profiles influencing supply and demand, property values, and so on. And shopping around, because of the sparsity of care, again, particularly in rural Lincolnshire, is tricky. So the last assumption I want to look at is that old people who pay for care are all wealthy, right? So it's true to say that we interviewed a significant number of people who define themselves as comfortable and who had access to decent financial resources and were philosophical or even positive about the fact that they needed to contribute towards the cost of their care. But we also met a very significant number of people who were just above the financial threshold, some who were actually below the threshold, and looked at least on paper to be eligible for publicly funded care, and people who are buying in care with significant needs because at some point in the past they hadn't met the eligibility criteria. Worryingly, we found examples of people who were cutting down on care in order to manage their money. So, for example, here Florence comments, so they come 3 times a day and I spend £1,400 a month, which is always a lot of money. It's getting really difficult, and I've stopped having lunchtime calls twice a week to try and bring the cost down. Even people who might be considered well off with good resources can find their resources depleting very quickly. Residential nursing care, living care can easily cost £4,000 or £5,000 a month or more. And so even a substantial pot of money can deplete very quickly, for example, from the sale of a home. So what are the implications of all of this? As I started out this presentation saying, older people have often been very much at the margins in terms of thinking about social care and self-funded social care. So we think that much greater effort, or perhaps more consistent effort from policymakers and researchers to engage with the experience of older people who are paying for their care would be worthwhile. There's clearly a need to do something about information about care, how to find it, how to achieve information that's kind of tailored to your individual need or circumstance, rather than trying to navigate with generic information, which can often be hard to find and out of date. And as I said earlier, descriptions of finding care as nightmarish and difficult and horrendous can't be the mark of an effective and easy to manage system. But this is easier said than done, because the social care landscape, as I've alluded to earlier, is very complex and it's fragmented, and it changes as people come and go and services change. So it's a difficult thing to achieve. Older people, I think, should be encouraged to have an assessment of need from local authorities, as this can be an important way of getting advice and information, even if ultimately you're not eligible or you don't get care from the local authority. Care workers work incredibly hard to do the best they can in difficult circumstances. And when they fail because of issues such as staffing difficulties, funding, the low status given to social care, people leaving the workforce, older people, and indeed the families who support them, and indeed social care workers, suffer. Funding thresholds and arrangements have not changed for a decade. So this matters not just for people who need care, but for the millions of families and friends who are supporting disabled relatives. So social care reform is really pressing. And future funding models for social care may have to involve us all if we're to have a sustainable care service that's fit for purpose for you as you age, and if you should need care, not just as an older person, but at any point across your life course. I think there seems to be a need to improve public knowledge and awareness about social care. I know that by and large, we don't like to think about care or what might happen to us in the future. It's an uncomfortable thing to think about. But I think it is important to, at the very least, understand something about how care works, because it might help to appreciate sort of the massively valuable and essential role that social care workers do. And finally, greater acceptance of care being part of all of our lives seems an important general point. We can't be healthy or well without care as an integral part of our lives. And across our lives, we can probably all think of times when we've needed more care, when we've not been able to go on without the care of someone to hold us up, to support us, to get us through those difficult times. And older people who need care are no different, and yet it's consistently presented as something different. And people who use services, we hear about the cost of care, the burden of care, paying for an older population, care brokerage, care commissioning, but much less about the relationships that underpin all forms of care. So my last point really is that care is everyone's business, or it should be everyone's business. So thanks very much for listening. My name's Mo Ray. That's my email. If you want to carry on this conversation, I'd love to hear from you. And we've got masses of resources on our project website, briefings and research reports, case studies, presentations, and so on. Just acknowledging my research partners and colleagues, and also thanks to the Wellcome Trust for their generous funding of this project. Thanks very much.
Brilliant, Mo. Thank you so much for that really fascinating presentation. I think before speaking to you or listening to you speak previously about this research project, I would have been one of the 50% of people who had simply never thought about how care is funded, actually. It's a really important topic. We've got a few questions in the chat. I'd like to ask you a question, if that's all right. What do you see as the most successful model going forward? Would it be something like the NHS, where we're all contributing to that via taxes? Is that the right way forward, or is there a better way than that?
Well, I think it's certainly something that's being looked at. The idea that, you know, if we all contribute, because there is, you know, this sort of spreading of risk, if you like, in the same way that we spread risk around funding for the NHS. So I think that's certainly a model that's being looked at. And also the other thing that has been spoken about for a long time is the idea of a care cap. And in fact, that was actually included in the arrangements under the Care Act. but it was not implemented and was subsequently postponed. And that means that no one would pay over a certain amount of money for care. So once they'd got to a specific threshold, they would stop being responsible, and that would be a means of trying to address what we call catastrophic care costs, when people, for example, spend hundreds of thousands of pounds for a care home place, for example, by selling their home. But where the cap sort of sits, I think, would be quite important, because if it sits too high, then people who are who've saved all their life and have got a little bit, but they're not very wealthy, won't particularly benefit. So I think that's going to be quite an interesting thing. So I suspect there's going to be sort of combination of responses, but we're waiting still, of course, for our government to make an announcement, which I believe is forthcoming in the autumn.
Okay, well, I'll be interested to see what they have to say then, and if they take some of your recommendations on board. So we've got some questions from our online audience. So Paul's asking, is there a central carer offering from the state, even if it is paid for, or are all carers provided by private agencies?
It used to be the case that home care services were very much provided by the local authority, but that sort of changed really with the advent of community care, sort of in the 1990s. And so local authorities are increasingly now, they're commissioning services rather than care providers. So it's very unusual to find any local authorities with much in the way of home care provision, or indeed care home provision. They don't have care homes anymore either, or very, I can't think of a local authority that's got a care home anyway, but perhaps someone will tell me otherwise. So care is provided now through a range of means. So you can find care agencies that are private, so they are for profit. And sometimes they're commissioned by local authorities, so the care that they provide is under contract to the local authority, and they will provide care for people who are funded by the social services, or who are part funded by social services, and they may provide services to self-funders, but they may not. And then there are agencies whose business model is entirely funded around self-funders. That's their business model. And similar arrangement with local authority, with care homes. Some care homes have got some funded people from the local authority and some self-funders. And what we get there often is a significant disparity in the amount that people are paying for a bed. So a self-funder could pay £400, £500, £600, £700 more for apparently the same kind of care. And that's called cross-funding, where a self-funder kind of sort of supplements the cost, if you like, for the lower cost of a local authority funded bed, because obviously with commissioning power, they tend to have cheaper services. So yeah, and then of course there are the private and voluntary sector care providers. So they are not necessarily for profit. They are wanting obviously to develop their service. They will also sometimes work for local authority commissions, but they will also work as kind of community resources as well. So they'll charge, but they're not charging necessarily to make a profit. So right. I think it's all very. It feels all very long-winded, Kate, because it's really, really complicated. That's
what I'm saying. It's much less. Yes, it's much less straightforward than I would have hoped a care system might be. Actually, yes.
You'd think, wouldn't you? Wouldn't you think that? I mean, I think you just read some of my transcripts, and honestly, it makes your eyes water. There's some of the complex, convoluted, difficult pathways that people took to try and organise some care. It's pretty stressful at times. Not always, but often.
Yeah, okay, thank you. I think we've got time for one more quick question. Brilliant. So Stuart's asking, are there any charities such as Age UK that would help with impartial advice?
Yeah, so Age UK National have got a helpline, a national helpline, and that they are very good. I would certainly suggest that you could go to them for impartial advice. I think Independent Age have also got, they're a national charity, they've also got a helpline and also a whole range of resources that you can draw from. Age UK have also got written resources. And local authorities have a legal responsibility to publish information about self-funders and arrangements for self-funders. So your local authority is also a good starting point. Now, how you get that information can vary from local authority to local authority. What they provide can vary, but you must be able to get advice from them by law. It's a duty. And so there would be sort of three important sources that you could go and talk to in the first instance. And we've got some resources on our website as well. So if you want to go and have a look at some of those, that might be of help to you as well, or interest to you.
Excellent, thank you. And we've posted the link to your website in the chat there, so people can find that in the comments. Thank you. So I'd like to just bring in our second speaker now, Alex Carlin. Hi, Alex. How are you?
Hello, good evening. Good evening,
Alex.
everybody.
You've got a lovely leafy background behind you. So what I'd like to do now is just have a chat with you both. You've both been involved in our creative reactions that we've been running at Lincoln. So Creative Reactions is Pint of Science's initiative to link up our researchers with artists to create pieces of art inspired by the research presented here at Pint of Science. So I'd just like to ask you both a bit about how that experience has been. So Alex, I'll start with you. What's the name of the artist you've been working with, and what have they created?
Okay, so I've been working with the wonderful, wonderful Paige Whitaker, who is a final year art student here at the University of Lincoln. And Paige has created this audio visual piece called Reflecting, Reacting and Rehearsing, which considers the public's opinion of nursing staff and some of the difficulties that junior nursing staff or indeed nursing students may face when they move from their education into practice.
Brilliant. I should say I've actually had a look at the pieces of work that both of your artists have created. I find them both very moving. So do have a look at our Creative Reactions website. It's creativereactions.blogs.lincoln.ac.uk, and you can have a look at the art that we're talking about just now. So the same question to you then, Mo. Who have you been working with and what have they created?
So I've been working with the wonderful Naomi Jackson, and she's produced an e-zine, which is a fabulous resource and piece of artwork. And then the front page of the e-zine, she's also produced as a very large kind of oil painting as well. So there's a kind of standalone piece of artwork that's come out of the e-zine, and they're fabulous. She's been wonderful to work with. It's been a really positive experience.
That's brilliant. Now, Mo, I know you've worked with an artist before, but how have you found this process?
Yeah, really positive. Naomi was keen to keep a strong link, so it was very easy to have conversations, and she was incredibly tolerant about me kind of torrenting on about my research and, you know, sort of giving her loads of stuff and telling her loads of things. You know, she was very patient, very calm, very interested, very engaged. So it's been really very positive, and we've had a really nice connection, and also, you know, great support from Harriet as well, who you know, was involved at the end in terms of, you know, sort of bringing the work over the line and sort of checking that through with me. So it's been really good.
That's super to hear. And yes, I should really acknowledge our colleague Harriet Lewis in the art department at Lincoln, who has been supporting our artists, and also our colleague Matt Young, who's in charge of the public engagement unit here at Lincoln, who's also been spearheading this project. So Alex, how have you found the process? Have you ever worked with an artist before?
I haven't. So this is my first time working with an artist, and it was really, really enjoyable. And I found a similar experience to Mo there. Paige was highly engaged. She was really accessible, and I'm absolutely outstanded with how she could create my ramblings into a piece of work, a piece of art. I mean, she really did sculpt it beautifully. And I'd also like to pay a quick tribute to the people that also supported Paige with that journey as well. I know her mother was involved, who's also working as a nurse. Her peers were involved with the audio. So it was a brilliant piece of work. So thank you ever so much.
Excellent, thank you for that. So did the process of actually working with an artist make you think any differently about your own research, Alex?
Of course, yeah. And I think it's fair to say that as researchers, we are always encouraged to consider ways in which we can develop our research with public engagement and make sure that the research actually has impact and can be disseminated widely. And I think by producing a piece like this, it's actually far more inclusive, to an extent accessible. And I think as an academic, we frequently use peer-reviewed journals and we present at conferences, but I do sometimes worry that that kind of gets stuck within these academic communities, and actually, does the rationale behind why we do what we do actually reach the public forum? And that's why I think this was such a brilliant initiative.
Yeah, that's an excellent point. And we will be having a live event at some point in the future showcasing all of the pieces of art. And we're hoping to also have an in-person exhibit at some point once we're allowed to all gather in the same place at once. So keep an eye on our website for that. And so Mo, I'll ask you one last question. What are you hoping people will get out of seeing your research being presented through art?
Well, I suppose I'd slightly echo what Alex has said. I think that Naomi can support people to think about care differently and to just encourage a conversation about care, which I think is really important. You know, I think people, particularly perhaps younger people who might be less interested in care or might be thinking, oh, that's not really my stuff. I think she might do a better job of engaging those people than perhaps I can with my PowerPoint presentations. So yeah, so I'd really, really warmly recommend people to go and have a look and just, you know, have a look and see what you think and how it makes you react and respond, really. Yeah.
Excellent. Thanks so much, Mo. Well, we'll say goodbye to you for just now. Thank you very much for joining us.
Thanks for having me. Cheers.
Bye-bye. So I've already introduced you to Alex. Alex is going to tell us all about nurse training, and I think we'll see some very interesting points here, particularly in reflection with the pandemic and how that's made us all think maybe a little bit differently about our nurses. So over to you, Alex. Take it away.
Okay, so thank you ever so much, Kay and Tessa behind the scenes. So thank you to everyone who's joining us today. My name is Alex and I'm a lecturer and I'm a registered nurse. Now, I joined the university 4 years ago, and prior to then I worked as a district nurse in the Lincoln area. Now, I'm delighted that you can join me this evening to discuss the current opportunities and, to be fair, challenges for nurse education. More importantly, I would like to explore your perceptions and expectations of what is required of our nurses in the UK. And I'm going to offer you an alternative approach to education called problem-based learning. So together, I hope that we can build a nurse. Now, it's been a turbulent year for us all. The COVID-19 pandemic has changed the way we work, learn, and live our lives. Nurses have supported, treated, cared, educated, led, and delivered care in unprecedented conditions. And for that, I think we should all be truly thankful. Consideration of health and social care professions or professionals as heroes, I think, has really helped to acknowledge this very valuable workforce. But I also feel that perceptions have not always been like that. The pandemic has raised awareness and interest in nurse education and nursing as a profession. But what I would encourage you to do whilst we navigate through this talk is to consider if your perceptions and expectations have changed following on from the previous year. So my apologies if many of the images on these slides are female nurses. This was not intentional, but when you search for nursing images within internet search engines, often the images you see are uniformed and female. Not all nurses wear uniforms, and currently 11% of nurses on the register are male. Now, nursing is an attractive career regardless of gender, and this is a perception I just wanted to briefly address. And if you would like to know more about men in nursing, I would encourage you to search TEDx and Men in Nursing. My colleague provides a really useful insight, perhaps at some point after Pint of Science, though. So the title of a nurse carries a professional registration. More specifically, nurses are registered and trained according to 4 fields. So we've got the adult, mental health, child and learning disability fields, which are all regulated by the Nursing and Midwifery Council. Now, pre-registration nurse education, so a nursing course that on completion will enter you onto the Nursing and Midwifery Council's register, sits firmly in the arena of higher education. And one of the challenges that academics must consider is the best way to prepare students to become future ready and safe and effective nurses. Now, there is a perception that we are short of nurses, but you may be surprised to see that the admissions into nursing programmes has been fairly even over the past 20 years. Between 20 to 25,000 people have enrolled on a nursing programme. Admittedly, attrition is a problem. About 29% will drop out or interrupt their studies, but the number of students entering the register is increasing gradually. And so you may wonder, why did the papers say there was a nursing shortage when the Nightingale hospitals were set up in the first wave? Well, the problem is deeper than we simply need more nurses. And in truth, managing a person on a ventilator requires a nurse that has additional training and skills within critical care. We cannot build nurses overnight with this critical expertise. Now, the problem is that the supply of nurses is outstripped by demand. The demands on the health and social care sector has and will continue to increase. Still, there needs to be staff at the point of delivery, and some of the shortages that we see can be anticipated, with retirement being the main reason for nurses leaving the register. Of increasing concern, though, is the rate of nurses leaving the register due to stress and burnout. So this is about 26%, or a change in personal circumstances, which is around 24% of those that are leaving. Many of these nurses are between 21 and 40 years old. And so as educators, it's incredibly important that we build nurses that feel able to stay in the workforce. Now, to register as a nurse, students are required to meet a minimum of 4,600 hours of study, which consists of a 50% split between practice and theory learning. In 2010, changes in nurse education meant that students were required to also complete a degree or beyond in order to gain registration. Consequently, a nursing degree is not for the light-hearted. It takes a considerable amount of commitment, time and study in order to achieve the goal of a degree and professional registration. But once you're there, you have your ticket to a highly rewarding and international career. Ultimately, we'll always need nurses. So, I'd like to pose a question for a moment. Now, consider that you are about to build a nurse, just like you would when you're cooking a meal, for example, a curry. You need to select your ingredients. Now, what characteristics and qualities would you like to include? Now, drop down the first thoughts that come to your mind. Now, you could base this on your own experience of receiving nursing care, or perhaps the experience that was received by a loved one. This could have been end-of-life care, or even something simple like a vaccination. What was good about the nurse that provided that care? Or perhaps flip it. What should the nurse have done differently to improve their care? Now, I'd like you to make a note and add them to the chat when you feel ready to do so. Now, I also want you to consider a way in which higher education could potentially build nurses which includes the characteristics and qualities that are starting to formulate on your lists. Could this be achieved in a lecture theatre? Or is this a value that's a little bit more innate? And herein lies the problem. Within just a few months, I was teaching cohorts of 250 nursing students early in my academic career. And I struggled, in truth, to really see the benefit for students. And I also got really hung up on a concept called the theory-practice gap, whereby we teach theory, but how does this actually influence practice? Now, as a nurse educator, I could stand and talk for hours on palliative care, the theories and concepts, but does that really prepare a student for the challenges of supporting someone who is in pain and imminently dying? To hold somebody's hand and demonstrate empathy, to actively listen and be there when somebody is vulnerable, to consider the person as a person, not just a patient in for a set of procedures or processes, or, and I cringe when I say this, the palliative chemotherapy patient in bed too. Now, there has been a shift in higher education towards more active student-centred learning. And it could be that education is considered along a continuum, if you like, with the traditional Victorian lecture at one end, where I'm the expert and I will talk to you about everything I know, to the other end, where I am a facilitator of learning and students themselves actively engage and find knowledge. Now, I very much doubt that the characteristic written on your piece of paper could actually be acquired in a lecture environment. Now, in nurse education, we do already use a range of approaches. So we use simulation, virtual reality, small group activities, just to quote a few. But what I would like to propose to you as an alternative is an approach called problem-based learning. Now, we've all been there. It's March 2020 and your partner has diarrhea and vomiting. Now, your partner feels it's because of the curry that you made last night. You were trying to be romantic, but you may have rushed cooking the chicken in all that excitement. On the other hand, diarrhea is a persistent issue for your partner, so your dodgy curry might not have been the cause. Now, you head for a glass of water and you end up rushing to the toilet due to explosive diarrhea. You turn to clean up and the strike of fear comes to your heart. This was your last toilet roll. You couldn't get any more due to the stockpiling. Now, I could place you in a lecture theatre and talk about some of the key elements that are associated with this text. But instead, using problem-based learning in small groups of students between 5 and 8 people, they could explore this text to establish what is known, what is not known, and essentially establish the problems. Now, it could be that you and your partner has contracted gastroenteritis. For example, salmonella poisoning might spring to mind. It might be useful to explore how the digestive system works and what the pathophysiological changes could be. Equally, though, the persistent issue with the diarrhea for the partner might be a whole host of issues: bile acid and malabsorption, small intestinal bacterial overgrowth, irritable bowel syndrome, or even an early warning for something a little bit more sinister. Now, students would need to find out more about these topics and then present back their findings and consider solutions to the problems. Now, ideally, we encourage our students to use peer-reviewed texts and research to find that credible evidence. For example, the Lincolnshire Poacher Study, which is actively recruiting patients and people at the moment who might be presenting to their GP with irritable bowel type symptoms. Now, if you would like to know more, please search the Poacher Study Lincolnshire in your internet search engine. So, what is problem-based learning? Well, as I mentioned earlier, it's a student-centred approach where small groups of students receive a passage of text, and we call this a trigger text, and they find out about the associated problems. Now, the approach has been around since the 1960s and stemmed from dissatisfaction with medical education at McMaster University in Canada. This fresh approach used sick patients or people and their symptoms, and that presented the catalyst for learning. Now, problem-based learning is based on 2 assumptions: that learning through problem situation was actually far more effective than memory-based learning for creating a usable body of knowledge, and that 2, medical skills that were most important for treating patients were actually problem-solving skills rather than simple memorizing. Now, in 2018, Dr. Aidan Jayanth, who now works at the Lincoln Medical School, suggested problem-based learning as an approach to teaching within a final year nursing module. Now, we took the plunge and designed the module so that students progressed through a series of cases. And we received some internal college funding and evaluated the module using a survey and a focus group. The study indicated a preference for problem-based learning when compared to traditional approaches, but students also indicated motivational lows and some inconsistencies with learning and facilitation, which was somewhat anticipated. Now, the quality of the group interactions is critical to successful problem-based learning. Now, you can probably recall from school, there may have been times when there was a person in class who always answered all the questions and perhaps over-participated at times. And there may have also been that student who always thought the sessions were a bit of a waste of time and clearly didn't want to be there. Now, problem-based learning requires your learning to be in the hands of your peers. And consequently, if you're quite competitive and you want to do well, you are relying on other students to develop your knowledge. You must work with others, lead and organise your group, and potentially manage conflict. Now, it's these more hidden, softer skills that's what I find so incredibly interesting. And this is the area that I'm carrying out further study on. Okay, so let's just return to those initial expectations and perceptions that you were considering. So you were looking at the qualities and characteristics that you would like in a nurse. And I'd like you, if you haven't done so already, to select one and just add them to the chat. Now, in addition, I just want to pose another question. Do you think that universities and higher education are the best place to prepare and equip nurses? Again, add your thoughts into the chat, and I would encourage you to answer honestly and openly, because I really would like to hear your views. So thank you for listening.
Superb. Thanks so much, Alex. Really thought-provoking there. So I think we'd like to have a quick look at some people's responses to your question about what characteristics a nurse should have. So yeah, compassionate. Brilliant. That's a great suggestion, James. I'd hope so. Courageous. Yeah, in times, I think, especially during the pandemic, I'm sure that's been very important. Authentic efficiency. Yep. Brilliant. Are these the types of things you were expecting people to say, Alex?
Absolutely. Compassion and care, and we actually have the 6 C's, we call them, and they stemmed from a significant document produced by the Department of Health following the Mid-Staffordshire atrocities. In truth, there's no other way of saying it. So you may have heard or may not have heard of the Francis Inquiry or the Francis Report that looked at some of the care, and I'd like to think that not a single nurse would actively go to work and not offer a person within their care a drink of water or a meal. But unfortunately, this is what happened. And I know it sounds really simple. A nurse should be caring and compassionate, but clearly there's work to do here. But this, I think, is one of my arguments is I can talk about compassion. I can talk about how to care for people, but does that really make somebody compassionate and caring?
Yeah, that's a really good point, Alex. So I think we've got time for a couple of quick questions. So Melvin's asking, are there any aspects of nursing that are best taught via lecture theatres, whether it's live or online, as we've been doing recently?
And I think there's a really good point. There's a really good question. And I think it's useful just to unpick the live and online bit as well, because I think in truth, with the online challenges that we've had, there has been a little bit more transition back to the kind of didactic lecture-based approaches, because it is slightly easier, dare I say, because actually you could quite easily record a lecture and allow students to watch that almost like a box set series, your nurse education wrapped up in a Netflix account. I do think there are some areas of nursing practice that could be delivered in a lecture. The thing that concerns me is whether the person actually observing that acquires the knowledge effectively to be able to utilize it in practice. We have some excellent anatomy lecturers within the university that can talk all about, the respiratory system and the anatomy and pathophysiology around respiration. But it's whether that's truly been acquired and absorbed. That's the crux of the situation here.
Yeah, excellent. Okay, understood. So I think we have time for one more quick question. Excellent. James is asking, is problem-based learning better at postgrad or undergrad level, or does it matter?
That's a really, really good question. So yes, there is some clarification within the literature. And I was very fortunate, as part of my Teaching Innovation Fund, I was able to go to the University of Nottingham and observe problem-based learning with the medical students at the graduate entry medical programme. It does work slightly better with postgraduates. They have that educational maturity, the ability to very quickly find the relevant information. However, I'm going to challenge this because we have been doing this with undergraduates. And so I would like to think that with the right setup, structure and support, this could be used more and more in undergraduate education.
Excellent. That was a really full answer. Thanks very much, Alex. Okay, so I think we're just about out of time on the question front. So I'd just like to thank you again very much for joining us and giving us all those insights into how to build a nurse. So thank you, Alex. I'll say goodbye to you just now.
Thank you.
Thanks. Okay, so that's all from us for this year for Pint of Science 2021 from Lincoln. As I said before, you can catch all our shows back on the YouTube channel. That's the Pint of Science UK YouTube channel. You can find out information about the upcoming shows this evening at pintofscience.co.uk. And there's also a feedback form that I'd like you to fill in if you possibly can, and you'll find that underneath the YouTube description for today's event. And if you fill that in before the end of June, you'll actually be in with the chance of winning a prize. So thank you very much for joining us. And that's all from us from Lincoln. Bye-bye.